Today's topic is selection of teeth for complete denture, and it is going to be covered under these contents. Coming to the introduction, the selection of artificial teeth for edentulous patients requires a knowledge and understanding of a number of physical and biological factors that are directly related to each patient. Careful examination of the faces and teeth of people with natural teeth will develop a sense of dentofacial harmony that is the objective of tooth selection and aesthetics. A knowledge and understanding of a number of physical and biological factors directly related to the patient are required to appropriately select artificial teeth to rehabilitate the occlusion. The goals for this phase of therapy are to construct complete dentures that function well, allow the patient to speak normally, and are aesthetically pleasing and will not abuse the tissues over residual ridges. Anterior teeth selection. The anterior teeth are primarily selected to satisfy aesthetic requirements, whereas the posterior teeth are primarily selected to satisfy masticatory functional requirements. Both the anterior and the posterior teeth must function in harmony with each other and be anatomically and physiologically compatible with the surrounding oral environment. The three basic considerations while selecting the anterior teeth are the size of the teeth, the form of the teeth, and the shade or color of the teeth. Now coming to the starting size of the teeth, the following methods can be used to determine the size of the teeth. One is the pre-extraction records, others are anthropological measurements or anatomical landmarks or theoretical concepts and other factors. Now coming to the pre-extraction records, these are the records which were obtained prior to extraction of teeth. These include diagnostic or the study casts. These are the ones which are taken before the extraction in which the patient have their natural teeth, so you can directly measure the size of the teeth. In this, the actual size and shape can be determined, but the shade of the teeth cannot be determined. The next one is the pre-extraction photographs. In this, we take various angulation photographs of the patients and then we can use that for teeth selection. This method is useful to determine the size and outline of the teeth, and they can also help in determining the placement of the anterior teeth and the lip support. Then the third one is the pre-extraction radiographs. Depending on the radiographs, we can easily measure the size of the teeth, but radiographic errors like elongation and foreshortening should be taken into consideration. And the next, and teeth of close relatives like the patient's sons or daughter's teeth can be taken as a reference when the other three methods are not available. And sometimes extracted teeth which are preserved can also be used to select the size of the anterior teeth. Then the next method is using the anthropological measurements of the patients. Anthropological is nothing but a few authors, they have done studies from ancestors and they have come out with certain formulas to determine the size of the teeth. So in the first one, the anthropometric cephalic index, we measure the circumference of the head with the help of a measuring tape at the level of forehead, and the width of the upper central incisor can be determined by dividing the circumference of the head by 13, and then the total width of the upper anterior teeth can be determined by dividing the bizygomatic width by 3.36. Then another method is Berry's biometric ratio method. It was projected in 1906. He discovered that the proportions of the upper central incisor tooth, they had a definite proportional ratio to face proportions. He used the bizygomatic width and the length of the face. The length of the face is the distance between the hairline and the tip of the chin. According to him, the width of the upper central incisor is bizygomatic width divided by 16, and the length of the upper central incisor is the length of the face by 20. Then one more method was given by H. Pound. He evaluated the tooth width again by bizygomatic width and the length of the face. He divided the bizygomatic width by 16 to determine the width of the central incisor and length of the face by 16 to determine the length of the upper central incisor. Then coming to the anatomical landmarks, first is the size of the maxillary arch. In this, the measurements from the crest of the incisive papilla to the hamular notch, and from one hamular notch to the opposite hamular notch is measured. This gives the combined width of all the anterior and the posterior teeth of the maxillary arch. The next one is the location of the canine eminence. If the canine eminences are discernible, a line can be placed on the cast at the distal termination of the eminence. If the eminences are not discernible, the attachments of the buccal frenum can be used as a guide. A line placed slightly anterior to the buccal frenum will be distal to the eminence. Then a ruler can be used to determine the distance between the two canine eminences at their distal side through the anterior of the incisive papilla, and it is measured in millimeters, and this gives the measurement of the combined width of the anterior teeth, 6 anterior teeth. Then another method of marking the canine eminence is on the fabricated occlusal rim. In this, we can ask the patient to relax with the lips closed, and with the sharp marker or a carver, you can mark it at the corner of the lips. The vertical line drawn from this coincides with the pupil of the eye also. Then the nasal width as a guide. Boucher and Hoffman, they refer to the nasal index as a guide to select the anterior teeth as it relates to the interalar width to the space available for setting the anterior teeth. Werner et al. Suggested that the parallel lines extended from the lateral surface of the aloe of the nose onto the labial surface of the upper occlusal rim could be used to give an estimation of the midline of the upper canine tooth. Then the intercanthal distance can be used as a guide. The inner canthal distance is defined as the distance between the medial angle of the palpebral fissures. Then Abdullah in 2002, he has proposed a formula to calculate the width of the central incisor from the inner canthal distance. But however, the inner canthal distance was found to be greater than the combined width of the maxillary central incisors. The formula was inner canthal distance divided by 2 and then multiplied by 0.618. Then a case report in which they determined the canine position by multiple facial landmarks to achieve the natural aesthetics and complete denture treatment. In this, they had taken 2 reference lines. One is the interalar width, that is the alar line. They have drawn a line lateral to the aloe of the nose. Then another line is the line from the inner canthus to the alar line, that is the IA line. And they tried to relate the A line, that is the alar line, and the inner canthus to the alar line, IA line, with the cusp tip. They try to relate these lines with the canine cusp tip of the canine and the distal contact point of the canine. They found that both the interalar width was greater than the intercanine distance in both the sexes, and both the A and the IA lines failed to determine the canine cusp tip location, which was contrary to the conventional complete denture teaching. And but the A line was more clinically relevant than the inner canthus to the alar line to predict the canine position. But this study was done among Thai people, and among Indians again it differs. The interalar width again did not, according to a study, it did not coincide with the cusp tip position. Then coming to the theoretical concepts, by its concept, this concept was based on 5th century BC concept attributed to Hippocrates. The temperamental types were sanguine, nervous, bilious, and lymphatic, and named for the physiologic functions of the blood, nerves, bile, and lymph of the individual. The artificial teeth were arbitrarily selected to suit the patient's temperament. A bilious individual would be expected to have short, broad, tapering incisor teeth, whereas a sanguineous individual would possess long, thin, and narrow teeth. Then another concept is a dentogenic concept, and this concept has been explained as the prosthodontic appearance interpretation of 3 vital factors, that is the sex, personality, and age. Then Winkler had given another concept. In this, the teeth should be selected based on 3 different views, namely the physiological, psychological, and biomechanical point of view. The physiological biological point is that the facial musculature contributes to the aesthetics of the patient. So increasing the thickness of the denture base in the labial, in the buccal sulcus area can produce a puffy appearance. So this should be taken into consideration, and the dentist should evaluate the perioral tissues and arrange the teeth accordingly. And the psychological point was that a patient with a positive self-evaluation shows a broad smile, and the one with a negative self-evaluation shows a tight-lipped small smile. And in this psychological point of view, the campus line was taken as the plane of orientation. It is raised in happy people and it is tilted downwards in depressed people. Then in biomechanical point of view, the teeth should be placed such that they fulfill the biomechanics of the denture edentulous state. Then he said that it is not necessary to set the teeth on or outside or inside the ridge. Instead, they should be set in the neutral zone, where there is balance between the buccal and the lingual musculature. Then the next concept is the typal form theory, which was given by Leon William in 1970. According to him, the shape of the teeth should be inverse of the shape of the face. So according to him, whatever the shape of the face might be, the size or form of the anterior teeth should be the inverse of the shape. Then other concepts which are used are maxillomandibular relations. Any disproportion in the size between the maxillary and the mandibular arches influence the length and width and position of the teeth. And this is of more importance in class 2 and class 3 maxillomandibular relations. And contour of the residual ridge. The artificial teeth should be placed to follow the contour of the residual ridge. And the length of the teeth is determined by the interridge distance. So it is advisable to use tooth which are long enough to eliminate the display of the denture base. Then coming to the form of the teeth, it includes form and contour of the face, the patient's profile, and the dentogenic concept. Then the form and contour of the face. In this, the shape of the artificial tooth, it should harmonize with the patient's facial form whenever you are selecting the tooth. Leon Williams claimed that the shape of the upper incisors bears a definitive relationship to the shape of the face. He classified the form of the human face into square, tapering, and ovoid. The shape of the face can be determined by placing a tooth indicator on the patient's face. And this is positioned by allowing the nose to come to the center of the triangle and centering the pupils of the eye in the eye slots and holding the indicator with its center line coinciding with the median line of the face. Then the form of the face can be observed by noting the characteristic of each form in comparison with the vertical lines of the indicator. In square form, the sides of the face will approximately follow the vertical lines of the indicator, and in square tapering form, the upper third and the lower 2/3 will taper inward. In tapering faces, the side of the face from the forehead to the angle of the jaw will taper at an inward diagonal way, and ovoid faces will be determined by examination of the curved outline of the face against the straight vertical line of the tooth indicator. So Leon Williams had claimed that whatever might be the shape of the face, the shape of the tooth will be inverse of the shape of the face. So in case of tapering facial forms, the facial form tapers towards the chin. When you select the central incisor, the cervical area is tapered. Then coming next is the facial profile. In this, we observe the relative straightness or the curvature of the facial profile in a natural view. The facial profile can be determined by 3 points: the forehead, the base of the nose, and the prominent point on the chin. The facial profile can be straight or convex or concave. According to the facial profile, one can select the form of the tooth. The labial surface of the tooth, when viewed from the mesial and the incisal view, should show a contour similar to that when viewed what is viewed in profile. Then coming to the dentogenic concept, in this we take 3 factors into considerations, that is the sex, personality, and age. In sex, the feminine characteristics are they indicate softness, whereas the masculine characteristics, they indicate boldness and hardness. So in a female, the incisal angles are more rounded and the teeth have lesser angulation, while in males, the incisal angles are less rounded, and the incisal edge of the central incisor is parallel to the lids, and the laterals are above the occlusal plane in males, but in females they follow the curve of the lower lip. And in females, the distal surface of the central incisors, they are rotated posteriorly, with the lateral incisors overlapping the central incisor, whereas the reverse can be said for males. So in this we can see that in the female form we have rounded edges, and there is a softness which can be seen. The gum levels are also more harmonized, and in a masculine tooth form we can see that there is a dominant positioning of the canine, and the overall teeth they show a boldness. Then next is the age factor. These are separated by into young, middle age, or elderly. Coming to the incisal edge, in young patients there are presence of mamelons and cuspids with pointed tips, and whereas in a middle-aged adult there is incisal wear on the central and the lateral incisors, and coming to the adults, there is the abrasion, and there is loss of mamelons in the incisal edges. Then sometimes erosion also can be seen on the gingival third and the necks of the teeth. So it is depicted by careful grinding and polishing effectively, and different shades can also be used, and sometimes diastemas can also are seen in older patients, and then the age, the shade of the tooth is also changed in an elderly individual. In an elderly individual, the teeth are darker, and whereas in a younger individual, they are whiter. Then coming to the personality, the personality can be divided into vigorous type and delicate type. In vigorous type, it is depicted by by words like hard, aggressive, and muscular, and delicate is by like fragile or frail appearance. In a vigorous look, is given by wider centrals, and there is wearing of the central incisors and the canine with a sharp tip. And in a delicate look, it is created by rounded contours of the tooth. So in a young individual, you can see that there is presence of mamelon, and in an aged individual, there is attrition of the tooth. And in feminine form, you can see that there are rounded line angles, whereas in a masculine form, they are less rounded or more pointed. And in a personality, personality is usually the difficult one. In a vigorous individual, you can see prominent teeth, and whereas in a weak form, you have frail teeth. Then a new system for a case report where a new system was formed for choosing the form and size of the complete denture teeth. In this, all the 6 anterior teeth, they were connected by a lingual. They were connected lingually by a resin, and all of them acted together like veneers, and all the 6 teeth could be trying could be done at the jaw relation time, and the selection of teeth could be done, and different molds could be checked at the same time when pre-extraction records were not available. Then another method where they fabricated an individual set of composite teeth which were duplicated from a preserved stone cast. In this, the patient had come for the complete denture, and the patient had her own old stone casts. So what the dentist did was he took a silicone index of the teeth and poured tooth-colored acrylic resin, and he tried the teeth in the patient. But however, the teeth had to be refined. So depending on the size and the shape of this teeth, he made a preliminary arrangement of the with the teeth and made another index. And in that index, he used the composite resin, and he also filled it with dentin composite and also contoured it with enamel composite. Then he did wax up of this, and this was the final result. So based on the preserved stone cast, he had selected the size and shape of the tooth. Then next is the color of the teeth. Color can be described by means of hue, value, and chroma. Hue, it denotes a specific color of specific wavelength, and it should be in harmony with the patient's skin color. And value, it is the amount of color per unit area of the object. And chroma, it is the lightness or darkness of the object. Then translucency is another property which allows the object to partially allow the passage of light through it. And so while selecting the shade, we can think that enamel has a high brilliance and translucency, so the artificial teeth should also show the same properties for the natural appearance. Then while choosing the shade, the dentist should also consider the age of the patient. The young people have lighter teeth, whereas the color of the young people have lighter teeth, and the older people, they show dark and opaque teeth due to the deposition of the secondary dentin. And habits can also be taken into considerations. In smokers and alcoholics and pan chewers, they have discolored teeth. In such people, sometimes staining can be done of the teeth. Then next is the color of the hair and the eyes. Usually only the color of the iris is considered, but this is unreliable because the eyes are too small and they are too far away located from the teeth to significantly influence the choice of the color. Then the color of the patient's hair is also very unreliable because the hair color also changes with age. Then the patient's desires should also be taken into consideration. After coming down to 2 or 3 shades, the patient can then be shown and asked for his preference, so that the patient is also happy with his teeth. Then the shade of the teeth should be selected in bright natural light, and the observation of the shade should be made in 3 positions. One is along the side of the nose, and one is under the lids with only the incisal edge exposed. This gives an idea of how the teeth will look when the patient is relaxed, and under the lids with the cervical end covered and the mouth open. This gives an idea of how the tooth will look when the patient is smiles. Then a squint test can be done. In this, it is used to check and compare the color of the teeth with the color of the face. So the dentist should partially close his eyes to reduce the light and compare the artificial teeth or differentiates with the color of the face. The color of the teeth that fades out first is the least conspicuous, and hence it is the best shade for the patient. Then coming to the posterior teeth selection, it will be covered under the size of the teeth, form of the teeth, and the material. Then the size of the teeth, it is the divided into buccolingual width, the mesiodistal length, and the occlusal gingival height. This buccolingual width, the buccolingual width should be adequate to act as a table to hold food during trituration, and it should also be able to support the cheeks and tongue, and it should be in functional harmony with the musculature during swallowing, speaking, and mastication. An artificial teeth, the buccolingual width should be decreased so that the buccal and the lingual surfaces can slope out from the occlusal surface to provide a proper path of escapement of food during mastication. And it also helps in development of the correct form of the polished surface of the denture. Then if the buccolingual width of the artificial tooth increases, the forces acting on the denture will also increase, which will lead to an increased rate of ridge resorption. Then the mesiodistal width, the anterior-posterior dimensions of the posterior teeth are determined by the edentulous area between the distal of the canine and the ascending area of the mandible. So the mesiodistal width of the artificial teeth is selected depending on this distance. So the size of the teeth is size of the posterior teeth is decided based on this distance. And the posterior teeth, they should not be placed on the ascending area because the ascending area is inclined, and placing teeth there would direct the forces at an inclined plane. And this might cause the lower denture to slide forward. Then next is the occlusal gingival height. In this, the posterior teeth, they should be selected corresponding to the interarch space and to the height of the anterior teeth. The height of the maxillary first premolar should be comparable with that of the maxillary canine, so that it can have a proper aesthetic effect. And the interridge distance also should be taken into consideration. The height of the posterior teeth should be such that less trimming is needed, and the less trimming is needed. Then coming to the form of the teeth, under this we have anatomic teeth, non-anatomic teeth, and modified anatomic teeth. And first we'll talk about the history of the anatomic history. Anatomic teeth. In 1914, Geizy designed the true white teeth. These were the first anatomic posterior teeth to be developed. They were made of porcelain, and they resembled natural teeth with transverse ridges intended for tight interdigitations. Then modified anatomic teeth. In 1927, Geizy designed crossbite teeth. The maxillary buccal cusp was eliminated, and the parietal cusp occluded with the anatomic lower posteriors. The occlusal surfaces of all the posterior teeth were reduced, and these could be used for crossbite cases. Then in 1927, Sears designed channel teeth. In this, the maxillary occlusal surfaces, they had a deep channel running mesiodistally along all the 4 posterior teeth, and the lower posteriors were like a single ridge, which were half the buccolingual width of the normal anatomic teeth. and these articulated with the upper channel. These permitted unlimited protrusive glide. Then in 1930, Avery brothers they designed the scissor bite teeth. In this design, the posterior occlusal surfaces were ground like steps uh, with the angle determined by the condylar guidance. There was freedom in lateral excursion in these teeth. Then in 1935, French introduced modified posteriors. In this, he designed the upper posterior. The upper posterior teeth were similar to the channel teeth, but with a shallow buccolingual inclines. And the lower teeth, they had a sloping buccal surfaces that was placed below the occlusion. So only the lingual cusp contacted the groove in the upper. He claimed that this directed the force lingually, stabilizing the lower denture. Then in 1937, Max Pleasure, he designed the Pleasure scheme. In this, the lower posterior occlusal surfaces were modified to produce a reverse curve by tilting the tooth buccally, and he also claimed to stabilize the lower denture by directing the forces lingually. Then in 1942, John Vincent designed metal inserts in resins. He used circles of gold solder wire or stainless steel wires, and which were inserted into the maxillary posterior resin occlusal surfaces. And these teeth were set opposing French's mandibular posteriors, in which the buccal cusp was reduced below the occlusal plane. It was claimed that as the resin wore, the chewing force was concentrated in the center of the denture. And then in 1961, Sosin designed the cross blades. In this, the occlusal surface of the upper second premolar and the first and second molars were covered with vitalium. And during drying, the lower posteriors were removed and the denture was processed. And while during the insertion, the wax was placed on the lower permanent record base, and the patient was asked to produce the chewing movements. And the lower occlusal pattern, which was created, was converted to gold and processed onto the lower denture. Then in 1977, Levin modified these teeth by placing vitalium only on the maxillary palatal cusp for aesthetic reasons. Then coming to the history of non-anatomic teeth, in 1929, Hall designed the inverted cusp tooth. This was the first non-anatomic design. The occlusal surfaces of the teeth were flat with sharp concentric ridges around a cup-like depression, which was the inverted cusp. But they didn't have sluice way between them, so the escapement of food was not present. Then in 1929, Meyerson designed the true cusp teeth. This was also the cuspless posterior that had a series of buccal and buccal lingual ridges with sluice ways between them for the escapement of food. Then in 1934, Nelson designed the chopping block teeth, and this is a flat occlusal surface with the ridges. The mandibular ridges were placed transversely, while the maxillary ridges were placed mesiodistally. The perpendicular contact made by the ridges was claimed to have an efficient shredding mechanism. Then in 1939, Swenson designed the non-lock teeth. He designed a flat occlusal table with sluice ways for shredding and allowing food to escape from the occlusal table. Then in 1946, Hardy designed Vitalium occlusal VO teeth. These were the non-anatomic teeth which contained metal inserts in the occlusal surface. The two premolars and the first molar were joined together, but with a separation within buccally. The Vitalium ribbon was embedded onto the occlusal surface in a zigzag manner, slightly raised from the surface of the resin. The contact of the upper and the lower teeth was on this metal ribbon, and then this improved the cutting efficiency. In 1951, Meyerson Tooth Corporation designed shear cusp tooth. These were the first cross-linked acrylic non-anatomic tooth to be developed. And then in 1952, Cook designed co-masticators. This, the mandibular premolar and the first molar were flat stainless steel castings with diagonal holes on the occlusal surface, that's low buccally. They occlude with the occluded with the flat upper porcelain teeth to grind the food. Then in 1957, Bader designed cutter bars. The cobalt chromium metal cutting bar was placed on the occlusal surface of the lower posteriors. And they opposed flat porcelain teeth. In 1967, Faraj designed linear occlusal concept. In this, the single mesiodistal ridge was placed on the lower posterior teeth opposing the upper teeth. Then coming to the definition of the anatomic teeth, these are artificial teeth that duplicate the anatomic forms of all the natural teeth, or teeth that have prominent cusps on the masticating surfaces and that are designed to articulate with the teeth of the opposing natural or prosthetic dentition. Or this can also be defined as teeth with cuspal inclination that tend to replicate natural tooth anatomy around 30 to 45 degrees are considered the anatomic teeth. Modified occlusal forms or semi-anatomic teeth are those with a 20-degree cuspal angulation cusp incline. The anatomic teeth, they are more efficient in cutting the food, and they also help facilitate the development of bilateral balanced occlusion, and they look like natural teeth, so they are more aesthetically pleasing, and they also provide a resistance to denture rotation due to their interlocking. While using the anatomic teeth, it is mandatory to use an adjustable articulator, and eccentric records must be made for the balanced occlusion. And the cuspal inclinations, they generate more force during function, and the mesiodistal interlocking will not permit settling of the base. Then non-anatomic teeth, these are defined as a tooth which is designed on mechanical basis rather than anatomic basis, having a flat or nearly flat occlusal surface. The major objective of the special occlusal form is to prevent the destruction of the tissues and to preserve the integrity of the supporting ridges. While using the anatomical teeth, the closure of jaws occur over a broad contact of area, and these are more it is claimed that these are more useful and or easier to be used in class 2 and class 3 jaw relationships, and they generate minimal horizontal pressure, and it is a simple technique to arrange these teeth. And when the neuromuscular mechanisms are uncoordinated and the jaw relations are not repeatable, it is advisable to use non-anatomic teeth. And in case of diabetic patients also, due to the decreased forces created by these teeth, it is advisable to use non-anatomic teeth in diabetic patients. And in but these non-anatomic teeth, these are aesthetically inferior to the cusp teeth, and they do not completely penetrate the food effectively, so they are mechanically inefficient, and they cannot be corrected by occlusal grinding without impairing their efficiency. Then some of the materials for the artificial teeth include the acrylic resin teeth and the porcelain teeth. The porcelain teeth, they show the wear is clinically insignificant over a long period of time, so the vertical dimension is maintained, and it also maintains its efficiency for years. But these teeth, they can cause abrasion to the opposing bolt crowns and natural teeth, so they should not be used against natural teeth. And they also make sharp impact sounds. And they do not bond to the denture-based material, so they have the diatoric holes into which the resin has to be penetrated, and so the porcelain teeth, they should not be used in reduced interridge distance, and it is also difficult to do occlusal corrections in these in porcelain teeth because chipping of the porcelain might occur, and it is also difficult to polish the porcelain after trimming. Then the acrylic teeth, the wear is clinically significant over the years, so there is a loss of vertical dimension, The occlusal surfaces are altered by wear in 5 to 7 years, and they are usually in 5 to 7 years they are usually worn to a reverse curve, but they show minimal wear to the opposing gold crowns and natural teeth. And they also bond chemically to the denture-based material, and occlusal corrections can be made easily, and polishing is also easier with acrylic teeth. So once the jaw relation is done, a few landmarks can be carved onto the occlusal rims, which can help in the selection of the teeth. One is the midline, which will help in symmetrical positioning of the maxillary central incisors, and the other is the canine line. This canine line can be will determine the distal point of the canine, or this can be marked by near the corner of the mouth, and a high lip line can be marked on the patient, marked on the occlusal rim when by asking the patient to smile. This will determine the visibility of the anterior teeth. Then on a tooth set, this is according to the Dentsply system. The Dentsply system, it has 2 numbers and 1 letter. The first number, it indicates the classification of the facial form. So when you look into the Dentsply catalog, you can see that the classification is the first number is square or square tapering, square ovoid or tapering ovoid or ovoid, and square tapering ovoid. And the second letter, it denotes the proportion of the tooth, that is the long, medium or short, and combined with the facial contour, that is straight or curved. So after checking for these two, then we select the first and the second number. Then the third letter, it denotes the width of the upper 6 anterior teeth. So this is selected by this is measured from one distal of the canine to the other distal of the canine, and this is measured with a flexible ruler, and that letter is taken, and then the mold can be selected. Then Dentsply, it also has it also gives which opposing tooth to be used. It has a chart, a combination chart, which occludes aesthetically and functionally with the selected anterior mold. So when we select an anterior upper mold of 11D, it shows which lower anterior teeth to be taken, and also the posterior teeth which have to be used. Then in conclusion, we should select anterior and posterior teeth by evaluating the requirements and the oral conditions in each individual's case, and learn to utilize the many forms of the teeth to a good advantage. The biological, physiological and mechanical principles need to be considered and carefully coordinated before coming to any conclusion. These are my references. Thank you.